Well, we'll start off with our patient here, and so we're going to presume that everything diagnostically is proven. This patient has SI joint pathology, and then we'll perform a fusion and assisted by our superstar assistant here, Molson, and we'll show you how I do the SI joint fusion. And a lot of this, as you'll see, is really an understanding of what you're seeing on imaging to make sure that we're not hurting any of the anatomy, namely S1. L5, and then going to caudal where you can injure the superior gluteal artery coming out of the greater sciatic notch. And so this is the way to minimize that. So if we can look down here at our specimen, we marked off an area called the PSIS, which is right here. So I can palpate that. That's the PSIS. I come down here, I feel the back of the femur, and I do a line up here on the mid-axis of the femur. So this line down here, the line down there, and I divide this one into thirds. This is my typical starting point. And the reason why I choose this point is because if this is the PSIS, the pelvis comes up like this, around like here. This is the abdomen. This is a never zone for clear reasons. Down here is the greater sciatic notch. This is a never zone for clear reasons. So this surface area here gives you a very safe place to start without putting your guide pin in places where you don't want it to go. So once I have the starting point marked out, I'll take my guide pin and I'll insert it under an outlet view typically. And I'm going to start right here. I'm going to go into the sacrum. And once I kind of get into here, we're going to kind of figure out where we're going. Okay, so let's take a shot right here. So that tells me I'm too far caudal. So now I'm going to go cranial. Shot there. Okay, I'm still too caudal, so I'm going to go even just a little bit more cranial yet. This is going to be in line with my inlet view typically, so I'm going to go cranial. Shot here. And we're really walking it in. That looks pretty good there on this outlet view. So this is where I did my cranial caudal. Now we're going to go to the inlet view. And so as the C-arm switches around, the inlet view, like we talked about on the lecture, is predicated with S1 overlying S2. So we get a very dense anterior cortical line. So this is the perfect inlet view. And see, I'm going to move my specimen a little farther down. Shot there. Good. And let's take 5 degrees off of the inlet view. And so what I'm doing, I'm aiming clearly to anterior. So I'm going to shift my, let's do a couple less even. I'm going to shift my pin to aim posterior. So I'm going to go here. I'm going to aim posterior. Shot there. And I'm going to go even more posterior. Shot there. Perfect. So now, as you can see, I'm going right into there, right into the middle of the body. You can see on this specimen where the indent is there, closer to where L5 is going to be sitting, and that's that recess. So there's a couple different lines on there. The anterior line there right in front of my pin, and I'll show you when the big pin goes in there, is S2. The indent there is S1. So the indent is where L5 is going to be resting. So once I'm good here, I'll go back to the other view and confirm I'm okay on the outlet view. And if I am, I'll make my skin incision. Go ahead, outlet view then. So I'm going to take 11 blade next. Perfect. All right, and take a picture. And so I did what's called a biplanar correction, and so I moved caudal when I moved more posterior. So this happened. So now I'm gonna go ahead one more time. So now I'm gonna aim cranial. So I'm gonna go this way and aim cranial. Shot there. Good. So now I like my trajectory. So now I'm gonna swap out I'm gonna make a small skin incision. I usually make it in line with the sacrum. And then I swap out the small pin for my guide pin, my real guide pin. The reason I start off with a small one is because I think you can do a little more damage with the big pin. So the small one is like a little hypodermic needle. I put that in there. I call it, I kiss the tip. So I'm right where the other one was. Now I kind of repeat everything I just did. Shot there. Good. I'm going to go a little more cranial. Shot there. Okay, so that's going right up in that safe zone. I'm going above S1, below presumably where L5 is coming. So this looks good, cranial caudal. So let's switch around to the other view now. If I'm looking good, then we're going to kind of tap this in with a mallet to kind of embed in the periosteum so we don't skive as we're putting it in. Good, so I'm going to aim posterior. I'm moving my hand posterior, take a shot. Good, so we're looking pretty good there. I might just slide ever so slightly posterior. Shot there. All right, that looks good. So Wilson, why don't you give me a tap, tap, tap on that mallet? That's perfect. Okay, now I'm gonna switch to the wire driver and on oscillate. So when you're ever doing percutaneous surgery without guides for, like in this example here, you always go on oscillate. That way you don't bind up any of the soft tissues in the pelvis. So shot here. I'm gonna aim subtly anterior on oscillate. Shot there. Shot there. Good, so now you can see I'm going right in that safe zone. So we'll switch views to the outlet view. So this was anterior and posterior, and I'm looking pretty good in this view. So as I switch to the outlet view, that's gonna be cranial and caudal adjustments. And we're looking good. I'm going to cranial, so I'm gonna shift it caudal. So I'm gonna drop my hand a little bit in line with my inlet view, shot there. I'm gonna go just a little bit more inferior. And an oscillate is I can kind of mill that where I need it to go. That's perfect. So I'm going to go just a little bit more. Shot there. Okay, so I'm looking good here, and I'm going to go confirm on the other view that I'm in the right trajectory. So I like to shift my hand and aim the drill at the other beam so I know which direction to change my hands. Take a picture. All right, so let's take a 4 or 5, maybe a little more off the inlet view. All right, let's try that one. Good, so that's, see how the density changed there in the front? So now I have that very reliable inlet view, and I'm looking good. I might be erring a little bit in the anterior side, so I'm gonna mill it out a little bit more posterior. Let's see what that looks like. Shot. Good, so we moved it there. So now I'm looking pretty good, so I'm gonna kind of put that guy all the way in. Shot there. And I want to go all the way to midline. Shot there. Good. So I don't cross midline. So just in case I want to do bilateral SI fusions, I can maximize the length of both the sides. So let's go to the other view, make sure it looks good in the other view. All right, so we're looking perfect. We're just a little bit past midline, because this patient is going to get unilateral. So I extend my incision just a little bit. I take my pin, and I slide the knife right along the pin. I don't do any cutting in there. I'm simply slicing fascia. I just go right down along the pin, on bone, straight back out. And then I measure so we can start getting our implant ready on the back table. So I measure this right down to bone. And I don't have my glasses on. What does that read? Is that 70?
95?
All right, yeah, so that's a long one on there. So let's just do an 80. We'll do an 80 because I'm a little bit past midline and we want to go too far past. So once that's down there, to save my growing finger arthritis, what I've started to do is take these 2 dilators in here, open up the fascia. Then I take these out, and I put my finger into the wound, and I go all the way down to the ilium. And what I'm doing is using my finger to scrape off a little bit of the gluteus medius and minimus from the iliac lateral wall. And that allows the eventual implant to sit perfectly flush without pinching down any of that glute. So once I actually have my fingernail on the ilium and I have a good area, probably about this big on the bone, cleared out, I'll put my dilators back in. This just generally spreads the glute muscles without really ripping anything. This one goes down right next to it, has teeth on it. And what we're doing is we're kind of gripping into the ilium. And so let's put this here. And if you give me a lot of good counter force right here, so when I mallet it, I don't knock the patient off the table. All right, so it just gently kind of goes into the ilium. Now we'll take those stabilization pins as I lock this in. Then we're going to put this pin in. And I use these simply to drill into the ilium to hold the guide in place so that it doesn't switch out of place when I'm doing the surgery. Go real slow there. I put the other one in. These are especially helpful in osteoporotic bone where the implant or the guide system will will sometimes slide. So I'm going to dive down bone. All right. Going here. Perfect. All right. So we're done with this part. Everything's stable and locked in. So now we can put our guide in. This simply helps us for the second. Remember my talk, I said there was 2 critical steps. The first one is putting this guide pin in perfectly without injuring L5 or S1. The second critical step, if there's one, is to find the SI joint so we can completely destroy it and make sure it fuses together. So we're going to over drill, like with any cannulated screw system. This is essentially the inner diameter of our screw. This is also helpful to find the SI joint. So in high speed, because we're all protected, I can go in high speed forward. Good, so it should be at my side of the SI joint. Let's shoot. So I'm on my side of the SI joint. If you're confused on this part, you're not quite sure where you are, another view, which some of you may be familiar with by putting in S2AI screws, for example, let's roll back simply 10 degrees of roll back. And this can help you look down the SI joint sometimes to confirm where you are. And some patients, remember, the SI joint's very oblique, and you can see that the drill's right by the SI joint. Oftentimes you can hear it go across or feel it go across. Yeah, a little dip right there, shoot. That was me going across the SI joint. So now I'm on the sacral side of the SI joint. And now I'm going to kind of swallow up the drill. Take a shot there. I don't want to cross midline. Just going to swallow it up. Shot there. Good. Now, oftentimes, we'll take another pin. The pin comes out and is stuck in the drill bit. So I'm holding everything in place. Let's put the next 3-2 right in that hole that I just drilled. So the pin stayed in there. This one, I kind of Robin Hood this thing. So when I'm in the old hole, now I'll take the 12 millimeter drill bit. So this is the next critical step where we're going to find the SI joint. There's a laser line on here, and that's what we're going to use based on tactile feedback and imaging feedback to locate the SI joint. So we'll put this over our pin so we know exactly where we're going to go. I'm going to go high speed. I'm going to stop at my side of the SI joint. Let's shoot. I'm on my side of the SI joint there. And just what Dr. Chapman was saying, you always have to be on high speed because that's where you can get that tactile feedback as you're putting the drill in. So I'm going to go across the SI joint. I just went across it. I rotate this knob until it's a little bit past this black laser line. Now I know where my next tool is going to go in and debride the SI joint. Now I'm going to go across on slow speed, and I'm going to grab autograft from the sacrum to regraft the fusion zone. So let's do a shot there. You see the drill's in there just a little bit into the ala to get bone. As it comes out with the real patient, all of this is autograft in your drill. And that can be used to regraft the patient's fusion zone. So once that's done, the next step is decortication. And so this instrument I put in here, as I rotate this around and around, this instrument kind of comes out here and just takes out all of the cartilage and all of the contents of the SI joint. It also has a cutout right here that you're able to see on fluoroscopy to prove that you're kind of in the area of the SI joint. So I pop this in. I put the blade perpendicular to the beam. Let's do a picture there. And so this one tells me I'm going to go in just a little bit farther to get the SI joint. So I screw this in. I give this a tap. We're going to go in just a little farther. Let's take a shot there. There, I just moved in. So I am on the sacral side of the SI joint. So now we're going to start till we feel a little bit of resistance, and I'm going to start turning this. And you can see how far you're out. By this, there's a little dial on here which tells you how far your implant is out. You can also do on the fluoroscopy to see that as I go back and forth, getting it all torn out. And then what you can see is we'll do this will be the caudal extension. So let's do a shot here. And now as we rotate it around, this will be the cranial extension shot there. And so now let's do a quick live fluoro as I kind of show you what this is going to look like as we go around and around. This is just really inside scraping out the SI joint off. And once I'm all the way out, what I've been doing lately to increase the fusion zone is I back the decorticator out, and then I redo everything that I just did to increase that fusion depth. There's just more room for you to inject bone graft and make sure that you're getting the subchondral bone on each side completely decorticated. So we'll go around and around and around. And sometimes the younger patients, this is really, really taxing to get it all decorticated. All right, so I am all the way forward, all the way back. So I'm going to take this out now. And then if in the real cadaver setting, we would, at this step, I'll show you this. I'll show you the tool that we use. But this is attached to a suction device. And you put a green bulb right into here. You put this in here, and you squirt out all of the autograft. And you can collect this in a basin and then put that back into your injectate, so you're really injecting a large quantity of bone graft. After that's done, everything is cleared. We take the bone graft, and we're going to inject bone graft. And so you put your bone graft, your autograft, and bone graft extender into here, and that's what you inject into the SI joint as bone graft material. So we're going to put this into the SI joint. And then I take a shot there, make sure I'm kind of where I want to be. That looks pretty good. I'm going to go a little farther. And then this is the bone graft. So as you inject this, you can watch it go in, and hopefully it goes where we want it to go. So live fluoro on. So you see they're injecting our graft. This is the bone graft that we put in there. So that's off. So that's our bone graft. That's what's going to turn into the fusion zone across the SI joint. So when we back this out, and then I'm going to put my pin back in there. I'll take a Y driver empty next. And so now we're almost done with the fusion part. So we're going to back out these pins. Here's one back, and here's two back. Oops. And then I'm going to take out this inner sleeve. Then we'll take our implant. And also let's slowly together guide that over the implant so I don't lose track of this guy. And the next step, when we get the implant in, we're going to go about 80% of the way in. We will not do final tightening on this view. So, good. So then I got to go here. I go reverse to clear soft tissues. Then I go forward. Get about 80% of the way in there. Shot there. Okay, we're going to go with more. Shot there. A little bit more. Shot there. Okay, so I'm going to stop here because we're almost all the way in there. Now is what I kind of do a final tightening. So this view, we're going to go to an AP. We're going to roll back about 30 degrees. So I take everything out at this point. This is embedded. I pull this out. And then this view, remember the pelvis is sitting on the table, it's prone. So the pelvis is sitting down there like this. This beam is going to look down the outer table of the ilium so we can watch that our washer is going to be completely flush against the ilium. This step, I also then take my finger and I go underneath the washer to go around and clear out any fascia from underneath it. So I put my finger in there, I can feel the washer. I go down. Oh, thank you. Down, down, down. So I am on bone now. So let's take a shot there. Good, so you can see how I'm on bone. Now, this is the step where I'm really gonna compress. So as I turn this down, I feel it. It's getting harder and harder. Take a shot there. You can see how the bone's actually compressing in. Shoot there. So the whole ilium and SI joint are squeezing together, and those interdigitations that we looked at before on the lecture are now keying in, and that's what's going to give them this instant stability. So once I'm satisfied that the washer is flush, I've maximized compression, we're going to put in the anti-rotation screw next. So we're essentially done with this primary fusion part. So let's go back to the inlet view. And so now this is kind of easy. It's all guided. You can do it freehand if you want, and oftentimes because I do a lot of pelvic trauma, I'll do it freehand and do different implants. But if you don't, this is kind of the easy way to do it. On the inlet view, you put it through this, we'll see if I can back it up. You put it through the far one here, so it's slightly convergent. And then I'll do a little trick, as I'll use my finger and slightly kind of push it out to be more parallel. But if this will be safe, if I'm directly under my primary implant, this is going to be very safe. So I kind of push this in here, take a shot there. I'm going to go a little bit more posterior. So I'm going to put here, I'm going to go a little more posterior. So I don't want to be able to see it. Shot there. I'm going to go a little more posterior even. Shot there. So we should not, yeah, so that's going to be fine. It's going to go right underneath this implant into the kind of S1, S2 area. So let's go to the outlet view. I'm going to go in about 1 centimeter on oscillate. There we go. We'll see what this looks like. Good, so I'm going to take this in just a little bit farther. Shot there. Shot there. All right, and then final shot there. So if I go any farther, clearly I'm going to injure S1. So that's why I'm not going to go in there. So I'm going to measure this one. And we are measuring let's measure a 43 or 44. So I'm going to do a 40. I take this drill and all I'm doing here is punching the outer cortex. I go reverse, 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 clear soft tissues, and I just go pulse it till I just punched outer. I pop this off, and then as I rotate this around and make sure that my pin's not coming out. My pin is staying in there. Hold it in there. And then we take our 40 anti-rotation screw. I usually use 2 screws just because the concept is if you have 2 flat boards, 1 screw, you can rotate around that 1 screw. But if you put 2 screws in there, you're much less likely to rotate. Clear soft tissues in reverse, and I go forward a little bit. We want to make sure we're not driving our pin in. So at this step, I'll take a couple shots to make sure it's not driving in. So let's take a picture there. Good, and everything looks good there. So I'm going to continue to put it in. But every centimeter or so, I'm going to check an X-ray. Shot there. Shot. All right, once I'm almost down, then I'm going to go on 2-finger tight with power, or on a hand driver rather. As I kind of feel it right there. I just engaged the outer cortex. I have a little bit of a tight squeeze there. All right, take a picture. All right, once we're at this step, everything kind of comes out, and that's really it. So take a shot here. Good, so that's our final outlet view for the fusion zone. Let's go to the inlet view.
So, Woody, can you say how wide those screws are?
There you go. So that's a good demonstration of kind of how I like to do the SI joint. As I said in my lecture, there's a lot of different ways to do it. This is the way I prefer to do it. It just really allows me to squeeze that together, do a really good true fusion, just like the X-rays I showed, and is associated with some pretty good results.
So Woody, just says a point of reference, can you say how wide the small screw is and how wide the bigger one is?
The primary implant, the big one at the top, this was a 12. It's all based on that anatomy where we did the initial templating in the slide presentation. So I like to get 12s because it's big and robust and strong. You can also, based on anatomy, go to a 10 millimeter or an 8 millimeter. Many of our patients have pre-existing S1 pedicle screw placed in there. So the 8 millimeter one is nice to be able to almost touch the pedicle screw, and almost always you can sneak right underneath it, interdigitating with the S1 pedicle screw. So the 8 millimeter primary implant is helpful for that. The secondary implant is simply a bigger cortical screw. It's 6.5 millimeters that comes in the set. But if you're facile and you want to use something stronger or bigger or even a different company as a supplementary screw, you can do that too. Any other questions?
Any questions for Dr. Cross?
Yeah, hey, Woody. My trauma guys used to do this in kind of an open, invasive way, and once we got our spine robots, they've switched to using a robot. It seems like kind of the perfect case where all a robot does is kind of dumb. It just points you in the right direction, right depth, but it seems to work well.
It absolutely is. And that's the next step. We just got a robot up at Mayo Clinic, and we're gonna look at doing this once we've kind of ironed out the spine portion. We're gonna move into the SI portion, but it is ripe for robotic management. Upload your CT scan, and it puts it exactly where it needs to go.
Yeah.
I do use a lot of navigation for cases where if I can't get good preoperative imaging like we're getting here, which is perfect imaging, let's say they're put on a regular spine table, the knees are dropped, they're in tongs. I can't get good inlets and outlets reliably. So I'll navigate those patients, navigate the guide pin in perfectly on whatever navigation system we're using, and then I'll bring in fluoro on just one view to watch myself graft and decorticate and make sure all the steps, I'm not advancing the pin inadvertently. So definitely navigatable for people that aren't like super facile with inlets and outlets. It is easy to nav. It takes a lot of this guesswork of what's your perfect inlet, what's your perfect outlet. It takes that all out of the equation to nav it. So definitely an option.
Yeah, and you had a really important teaching point. Oftentimes the robot or nav will show the screws perfect, bring in independent fluoro, sometimes not so perfect. You really need two things to say it's in the right place.
Yeah, I like the instantaneous feedback of what I'm doing with moving and putting the drill in or the screw in. Nav, as we all know, you have no feedback like that.
Yeah.
Great. Yeah, thank you so much.
All
Any
right,
other
thank you.
questions?
How many have actually done an SI joint fusion?
Got about half, maybe 40%.
How many of you use a robotic versus a traditional two view? Robotic, show hands. Okay.
Yeah, most is fluoro guided. Okay, cool. So our next speaker is going to be Dr. Rada Skuyan talking.